This lecture is about chest pain and coronary artery disease. So we know that coronary artery disease or coronary heart disease is the #1 cause of both death of men and women in the United States. It includes several types of coronary heart disease, which include acute MI, angina pectoris, atherosclerotic cardiovascular disease, and all forms of chronic ischemic heart disease. The contributing factors for injury are related to coronary artery disease. So patient-related delays in seeking urgent initial treatment are due to a number of causes. And on page 536, it's really interesting why we delay. And despite the public and the health education that's been given, we still continue to delay. They really range from minimizing our symptomology all the way to self-treatment. So if you'll just review that, why patients delay. And then I think why that's important, knowing the reasons, is that's where we can intervene. Risk factors, modifiable risk factors do include smoking, cessation, dyslipidemia control, diabetes, increased waist to hip ratio, physical inactivity, poor diet, psychosocial stress, and hypertension. The AHA and ACC have a great chart, table 120-1, that looks at secondary prevention for patients with coronary artery disease and other atherosclerotic valvular diseases. If you just look at those parameters, that's where our plumb line is. We're trying to get our patients to those numbers. Types and presentations, that really falls under that pathophysiology section, and it's different for different causation, okay? So you can review, and I do want you to, I want you to review all of those. I think I've listed 8, 7 actually, but I want you to go back and pay particular attention to that acute ST segment elevation myocardial infarction, which is the famous STEMI that you hear about. And then I want you to look at the suspected MI with non-obstructive coronary arteries particularly closely, okay? Clinical presentation, again, all right, this is maybe the longest chapter in the book. It depends on the disease or the cause, the etiology. So I want you to review those as well. What does that chronic stable angina look like when it presents into that patient presents versus any angina equivalent? What's microvascular angina present and variant angina? And then how does that acute ST segment elevation MI present? And I'm going to drill into that one because you don't want to miss any of them, but you certainly don't want to miss that. Physical exam, I think that we have to be very thorough, and we've got to assess the precordium. And you know, that point of maximal impulse is so important. It tells us so much if it's not in the the normal anatomic location. You want to inspect thorax for vesicles and rashes, because what if the chest pain is easily explainable by a herpes zoster rash or anything else on the chest? So looking for those differential diagnoses. You want to look at the neck and assess particularly for jugular vein distension. The eyes, that fundoscopic exam, and looking for diabetic retinopathy or any other signs of hypertension. And again, I think I've told you previously, this will take time to become skilled at the fundoscopic exam really being a physical exam skill that you have, but just keep doing it. You've got to inspect periorbitally because there's some cues and clues, those xanthomas, or an early arcus senilis, where they have the little cloudy ring around their eye. They both can imply elevated cholesterol levels. You want to look for vascular lesions. Cardiac-wise, palpate for cardiac upstroke and that PMI again. Auscultate for murmurs or any abnormality. And in the lungs, you want to auscultate for adventitious breath sounds. Because when we are assessing, for chest pain, we did a whole lecture on non-cardiac chest pain. So you're keeping those differentials in mind. But the very first thing you do is you rule out coronary symptomology. What's going to kill your patient first? What if they have two things? And that's very possible. So diagnostically, we're going to do that 12-lead ECG in our office in primary care. An echo is part of working up chest pain and coronary artery disease. That coronary CT angiography is important. Stress testing is important. We do know it works better in men than women. And then you typically see somebody getting a anemia panel, a hemoglobin hematocrit. Actually, I do a white blood cell count and do with a differential electrolytes, magnesium, thyroid, those serial cardiac troponin levels. Those are those cardiac enzymes, and CPR, looking for inflammation, and then the BNP looking for heart failure. So there's those are typical. There could be outliers, but generally in the primary care setting, you're going to do the ECG and then call 911. Differential diagnoses, you do want to rule out non-emergent causes, GI, pulmonary, valvular, inflammatory, and skin, psychological disturbances. However, you want to rule out life-threatening events first: aortic dissection, an MI, a pulmonary embolus, and a spontaneous pneumothorax. And just wrap your head around that. Except for the aortic dissection, which the patient is so ill and dies quite quickly, these are things that you would know what the physical exam parameters are and what the normal and abnormalities would be identified. Management, it's all based on etiology. What's the cause? That's how we determine management. And I just want you to be familiar with that. We know that antihypertensive meds, nitrates, aspirin, and anticoagulants are so involved in the management of coronary artery disease and chest pain, but it's individualized. Then that special note with women in CAD, we often don't present as the typical classic chest pain substernal. It's a GI symptom. We die much more suddenly of coronary heart disease with no previous symptoms. And current data continues to show a disparity in diagnosis and management of ACS and acute MI in women. Now, read that section. It's super interesting and it makes sense, but it's really also very sad. Referrals, patients with comorbidities need to be worked up by a cardiologist for management. Assume it's coronary artery disease until proven otherwise. Patient needs to be educated about coronary artery disease and heart attack warning signs. I included on the last sign what we usually use for education, but what about those atypical presentations? Again, broaden your scope. Angina symptoms are often present days to weeks before the onset of acute MI for anyone, but particularly women. So careful management of comorbid diseases, as well as a thorough understanding of their disease and medical regime, is imperative for patients and families. We've got to educate women and their families about risk, the unique presentation of women, and also have a conversation of the benefits versus the risk HRT, hormone replacement therapy after menopause. Educate about coronary artery disease and signs and symptoms of a myocardial infarction. And again, even your atypical presentation too. And you can even put it that way, divide it. That's fine. They also need to be educated that so many people will die within that first hour of a heart attack because they did not call 911. And with life-saving measures, people's lives can be saved. And then I do encourage all my family members that are capable, that have patients with known coronary artery disease or of any type, to be CPR certified. I think that gives them control and confidence. Thank you.